So, welcome to Advanced Patient Assessment. We're going to do some interesting things with this course. We're going to take a look at what you learned in basic patient assessment. Then we're going to talk a little bit about our laboratory values. We're going to take a look at nutritional needs of our patients. And we're also going to look at the people of age or elderly chapter. I'm going to have some assignments on bronchoscopies, and I also have an assignment on thoracentesis. So this should be kind of interesting. So what do we use for this? I use Wilkins' book. You'll notice if you look into Egan's that some of the folks who wrote the Wilkins chapters also wrote the Egan's chapters. So it's much easier for us just to go ahead and do Wilkins' books. Your assignments are going to be chapters 1 through 5, 7, 13, 18. The questions for all of these will be due when I go ahead and post it. Like I said, I'm going to put them in Blackboard, make it a lot easier on all of us. Short paper on the cultural look at healthcare, okay? Basically what I'm looking for is what is somebody else's look at healthcare and how do they do it? For example, there's different ones in Asia, different ones in Russia, things like that. And then just a paper on a geriatric or person of age patient problem. What do we expect? A lot of people think once you hit a certain age, your whole body falls apart. Not quite true, but for some folks it is. So we're just going to take a look at those to see what we have. And there's your bronchoscopy and thoracentesis. One of the things that we have done is we've moved patient-centered care to be the standard of the care that we give our patients. And the reason why we're doing that is that we used to just sort of dictate to them. Physicians told them what they needed to do, told them how they needed to do it in some cases they didn't, and the patient left with just, okay, whatever, and not a lot of information to tell them what they needed to do. We have developed and actually changed over time. And this is where the patient-centered care comes in. We look at these patients, whatever we're going to do with them is designed for them. It's an individualized care plan. The patient has to be involved with it. Do you wish to do this? The two of them need to talk together. I feel very uncomfortable using these drugs. Friends told me about these, or I looked on the internet and I saw some really bad effects for many what these drugs are. But it's up to the physician to talk with that patient, try to make them more comfortable so that they can have a better understanding, and then the two of them will come to a conclusion at the end. If the patient's not going to do it, the patient's not going to do it, okay? So the patient has to be part of the final say as to what's going to happen with their care. This was kind of an interesting question. If you read it, it talks about how well doctors know their patients and, what do they know about their health belief. And one of the things that we've noticed, and this has been for a long time, is that doctors sometimes do not have a very good understanding. They did a survey one time in the intensive care unit, and they basically said how many doctors in here think that this patient wants to be put on a ventilator and stay there for weeks if need be. And a lot of the doctors said, well, we believe that. We think that's what they want. Well, as it turned out, the percentage was like 40% were correct. The rest of them had not talked about end-of-life care, had not really wanted to know what was going to happen, to that patient. If they were on the ventilator, what was going to happen to the family? What was their belief and what is it that they wanted? What this is also talking about too includes us as respiratory therapists. Our patients will come and talk to us, they'll ask us questions, and we need to ask them questions too to see why did they ask what they're asking, okay? And so we need to be part of taking care of these patients. We also need to be part of talking with the families to try to understand. As a respiratory therapist, we do not diagnose. We do not really give advice. You can educate a patient. It's up to the patient to accept or not accept what we tell them. So what is patient-centered care? There you can see. And this is a beautiful diagram if you look at it, and you can see where we include the patient, and we need to make sure that the patient is our basic concern, and the family. A lot of times we forget the family has to be involved. In some cultures, the family is the one who makes the decisions for the patient, and we have to realize that, and we have to honor that because it's part of their culture. Individual care for the most part, empathetic two-way communication. There's lots of things that happen with communication. We would all like to think we're the great communicator. Anytime we say something, the patient and the family is going to understand it. If they don't, they're going to feel comfortable asking us about it. And when we finally go back and think about it, we're not even close to what we thought we were able to do. So we need to talk to our patients. We also need to listen to our patients. You know, these patients will tell you one of the reasons I don't like belonging to this healthcare plan, I get 5 minutes with the doc. What can I tell him in 5 minutes? Because he's the one who's saying, okay, blah, 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 blah. Nice talking with you. Call me if you need me. That really doesn't do much for us. The other thing is nonverbal communication. We all are pretty bad at that on occasions too. People sit there and they'll nod their heads and they'll yawn, and sometimes they'll pull their phones out, or they'll look at their watch, or they'll just sort of nod off. That is not going to do anything for that patient. That's not going to do anything for that patient's care. So if you look at Table 1-1, it's going to give you the different stages for your clinical encounter. The other thing is we have to have respect for this patient. Now, I know there's times that people go, well, you know, this guy just murdered somebody. How can I respect him? He did something that's going to be handled by the law. That's another thing that he has to worry about. He's a patient. He has to be treated like a patient. We cannot ignore the fact that he is a patient, okay? So think about that. Some of my pet peeves, you can see at the bottom here, we went to a luncheon once and some gentleman was talking about his asthmatic son. And I'm sitting there and going, he doesn't have an asthmatic son. He has a son who has asthma. The disease is not his son. And it used to drive me nuts when people would go, hey, room 345 needs a treatment. Well, who's in room 345 and what kind of treatment do they need? You know, I can't go in there and give the room a treatment. It's not going to work. I remember I was in the radiology department once. I was talking with one of the folks who worked down there, and a patient came down and he said to the patient, hi, Mrs. Jones, how are you? I'm fine. Well, we'll be ready for you here shortly. And he had checked her room number, checked her wristband, all of those different things. And I told him I thought that was really, really nice. And he said his director had told all of them, you cannot talk to these patients like they're rooms. You need to talk to them by their name. So there it is, the care plans that we're going to put together. They have to have the patient's preferences. Doesn't necessarily mean the patient's going to get it right away. In some cases, if you come in and you're not breathing well, the MDIs may not be working. We're probably going to use an SVM. That doesn't mean that somewhere down the line, we're going to not be able to switch you over, okay? We can talk about medication. We can see what is the patient's belief about the medications. You know, we need to tell these patients, do you have, you know, any questions for us? You have to, you know, be open so that you can talk with them. One of the things I found out when I was working is that the patients are a lot of times more open with us because we approach them in a better way, and we approach them with a more open attitude than some other folks do. So the other thing, ensuring privacy and confidentiality. One of the things we always remember is there's personal space, okay? Remember there's 3 different spaces, and each has their own set of ground rules, if you want to call them, that go with them. And we need to be able to understand that. One thing that we sometimes forget is that we have a tendency of moving things and we never put it back. Some of these patients can't get up and put them back, so we need to make sure that we put whatever we move back. The other thing we need to be able to do is to understand if you're listening to a patient, the last thing you're going to do is have eye contact, and the last thing you're going to do is have a conversation with them, okay? That intimate space is not for that at that point. So we really need to understand what's going on, okay? One of the things too that you see here, you have HIPAA and you have your PHI. There's a little 2 questions at the end. These 2 questions are not due today. They're actually due on Monday. Okay, so just to give you a heads up as far as those go. One thing too is we're looking at culture. This country is made up of a lot of diverse cultures. We have a lot of folks who have immigrated into it. And what we need to do is we need to understand what that culture is. Doesn't mean you're going to take a 6-week course on that, but you need to be able to learn more about it and then understand what happens with it. Some of the folks, when they come in, their significant others are the ones who speak for them. There's others who will never answer you or address you because that's not how they are trained to deal with this. A lot of people have an idea of what they think their health care is, and it's based on whatever their cultural background is, okay? The cultural competence means that basically we can interact with these folks. I may not believe what you believe, but however, I need to be able to take that into account when I'm dealing with you. So what do we need to do? We have to know a little bit about these cultures, and not the culture we're listening to in the news, not the culture we're listening to with the YouTube videos in some cases, but we really need to sit down and do a little research. And then we need to know how to speak to these folks, okay? We're not going to sit there and demand that they do something. We're not going to sit there and cut them off because, we just don't like what they're saying at that point. We need to be able to use the good communication skills that we're supposed to have. And some of these are your active listening, attending to their needs, asking them what their major concerns are. Give them some genuine concern over what they're telling us. What is it? It may seem trivial to us, but it may be major to them. So basically, one of the things we need to remember, as I mentioned a little bit before, we need to understand where these folks are coming from. They have different ideas about healthcare and where they have when they were back in their native country. And some of them, for example, may tell you, what do you mean I have to stay in the hospital? The doctor or physicians or doctors, whoever, used to give us medication and we would go home. What do you mean you have to listen to me? You're going to touch me? You can't be touching me. That's totally inappropriate, okay? So we need to understand that, and then we need to work with this patient to be able to get the outcomes that we need. How do we do this? First of all, be aware where your biases are, okay? If you say, oh, man, everybody who's green is really, really a bad person, and the green man with his family comes in, that preconceived notion is that that is a bad person. We cannot have those preconceived notions. We need to be able to talk with them. Mrs. Jones, Mr. Jones, whatever. One of the biggest things that drives me nuts, especially when the students are out of clinical, is they'll come back and go, oh, we talked to Nancy. And I'm going, well, who's Nancy? Oh, Nancy was the patient who was in this room who had blah, blah, blah. Well, how well do you know Nancy? Well, I never met her before until that day. And then, we called her Nancy because the nurse called her Nancy. You're going to hear me tell you this over and over again. It's Miss or Mrs. or Mr. until they give you permission to call them by their first name. Just because someone else does it doesn't give you the right to be able to do that. And then you guys are going to come together with this patient and you're going to figure out, how do we treat you? If the patient is doing well and they tell you, I do not like SVNs, they take too long, I don't feel like I'm getting the medication like I need to, I really want my MDI. If they're doing well, we can leave a note for the physician and ask the physician, can we switch from the SVNs to the MDIs and see what we can come up with. One other thing, if you tell the patient you're going to do something, follow through. I remember talking with a lot of patients. They would say, hey, can I have something to drink? And I'm going, I really don't know. Let me go find out. I would talk with a nurse. I would come back and say, unfortunately, you can't at this time. You have a procedure coming up in a couple of hours. Once the procedure is done and you're awake, we can then give you something. They would look at me and they would go, you're the first person who's ever brought me an answer back. I've been asking about this since 7 o'clock this morning. So make sure that you follow through on anything that they ask you. So here's how you do this. These are just some ideas for dealing with our patients. Take a look at them. I think they're pretty self-explanatory. Make sure you include the family too, okay? Because in some cultures, the family is, as I said before, is the one who's going to make the decision. And the family also needs to be there to prepare to help this person if they need some help. So we need to be able to address any concerns the family has. One where we see this all the time is with trach care. These patients are going home with trachs. We need to explain to the patient and to the family what the trach is, what's going to happen with it, how to keep it clean, how to, do your trach care. And then we can teach them how to do it. And hopefully when they get home that they will continue doing that. Unfortunately, in some cases, we had the patients come back, their trachs were occluded, and you talk to the family and said, what happened? And they're going, well, we really didn't want to hurt mom, so therefore we really didn't do it. Now, poor mom is having difficulty with her breathing. And so then we have to go ahead and we'll take care of that issue. And then we can still talk to the family and try to change things. So some of the learning needs that a patient has, we need to see, do they understand what we're telling them, okay? Or what we're hopefully instructing them on. And, that's so important. We can sit there all day and go, do you understand? Oh, yeah, I understand everything. Do you feel comfortable with what you have to do? Yeah, I sure do. Okay, well, great. Well, we're ready to, head on. And lo and behold, someone else comes in and they say, well, so-and-so was just in here. Yeah, I know. I don't have a clue what they said. I really don't know what they want me to do. But they were, really good people, so I thought I would go ahead and tell them I understood what was going on. The other thing, there's something like 40 or 50 different dialects in the Indian language in India. Most people don't speak all of those, and so we need to make sure if we're communicating with someone that we understand what their native language is. Sometimes in the hospital they do have the translators. Sometimes they have that phone that they can pick up and they can call. It's interesting sometimes when you're talking on the phone because the person you're talking to has a language barrier. It's a little bit worse than the patient that you're trying to deal with it. So just be patient. The other thing that we found out when we're working in the hospital, patients, families are sometimes will take their eyeglasses, sometimes they'll take their hearing aids, sometimes they'll take their dentures. We're trying to, talk with these patients. They can't hear us, they can't see us. They're trying to talk and they're slurring their speech. It's not a good situation. It's one, though, that we need to try to overcome. So we have to be prepared for that, all right? The other thing is we need to know, is this patient really going to listen to us? There were cases when we were getting there with the patients and trying to teach them a little bit about their disease process and that pulmonary rehab would be something that could help them and that we were going to start it in the hospital. And they would sit there telling us, you guys are just making this up. You're looking for more money. That's the only reason you told me I need oxygen. I've been doing well by myself. I don't know what the problem is. Or I just don't believe anything you've told me. I just think you've made it up for some reason. Okay? So you've got to be aware that just because you're in there and you're really excited, you want to do good, sometimes that good is not going to be accepted. So what this little graphic shows you, sharing goal setting, decision making has to be between you and the other person or the other person's family. And, you just have to be open to new ideas and new ways of doing things. I like this. I've happened upon this. Action plans should be SMART, very specific, measurable, action oriented, realistic, and time limited. Okay? You have to be able to say, we did this, this is what the outcome is going to be if you go through this portion of it. And, we're not going to give you 3 years to learn how to do an SVM. You have to have a time to be able to do it, okay? And so you have to work with them, and you're going to see on box 1.2 that they have a really good example of how to do this. And there it is. Like, again, you need to talk with the family and the patient and have them involved. The Joint Commission Speak Up Initiative gives you some excellent material to work with. They can look and see what's going on with the CDC. You can talk about respiratory etiquette. When you go into the hospital, a lot of these hospitals have stands for respiratory etiquette. If ask the person, do you know why that's there? What do you know about this? And then, what are the standard precautions? We're wearing a mask in your room. Why are we wearing a mask in your room? Today, it's because of COVID-19. Before, it used to be because the patient was coughing and we didn't want to share anything with them, or we were coughing and we still didn't want to share anything with them. So we have to be a team member. Some hospitals have team members where you meet maybe once a week or so. You all talk about this patient. What are your plans for this patient? What does the patient agree to do? And then basically you can decide, is the order of what we're doing a good order, or do we have to rearrange things? Okay, so we need to be able to talk with other team members because we want the best for this patient. Okay. And if you look at this, this tells you about basically how to do what you need to do with that. Remember documentation, documentation. There are people who are going to sit there and go, nobody cares about the documentation. I'm going to tell you, if you get that attitude, you're probably not going to be working for a long time, because documentation tells people what you did, when you did it, why you did it, what the outcome was, and what are you going to do to try to change that outcome if it's not a good outcome. All right, so take your time and document. It's not something that needs to, patient's awake, we gave them a treatment, yay, we're done. So always talk with others. When you're talking to someone coming on shift, one of the things we want to do is talk with them too. We don't want to bore them, but we do want to give them the information they need to know. I've had some really, really good reports where I knew a whole lot about the patient, and I knew what I was going to see when I went ahead and took care of them. If I got a lot of negative information, most of the time I just ignored it, because I need to establish my relationship with that patient. I don't have to continue the relationship that the other person has done. So we need to, think about what's important that you need, and because from my perspective and from your perspective also. SBAR is kind of an interesting thing. You see situation, background, assessment, recommendation. They use this on occasions, and the reason I like it, it's very compressed and concise, and everything you need should be on there, okay? Talk to your case managers. Our respiratory case managers were actually nurses, and a lot of times we could sit down and talk with them and explain, hey, this is what's going on, this is what we would think that you'd want to try to do, here's some really good things that need to be taken a look at. And a lot of them are very, very happy that we did that, because it helped them too when they were working with these patients. So make sure we take good care of them. In a patient interview, oh my heavens, patient interviews are so important, and sometimes we just blow them terribly, terribly bad, okay? And, basically look and see what you know with these patients and what's going on with them. Remember, you don't diagnose. You can feed back to that patient what they told you, make sure that you have an understanding of what they feel is wrong or what's right, And then make sure you document all this so that others, including your physician and whoever else is taking care of them, your other team members, understand where you're coming from. So there it is, patient interview. It's affected by you, it's affected by the patient, it's the cultural background, environmental factors. If they're sitting there watching TV and not paying any attention to you, this interview is going nowhere. Okay? If you're Barbara Walters, you probably have it, down precisely. I don't think many of us are Barbara Walters, so I'm not quite sure that we're that good. Okay? Patient has to feel secure. How do you feel secure? Is you have genuine concern for them, that you spend some time looking at them. Don't stand there and just stare in their eyes. Close those eyes and keep staring at them, because they're going to sit there and go, I think you're weird. You need to leave. But if they say something you don't understand, you can always ask, okay? And then you can say, I don't understand what's going on. Don't be answering your phone. This is not the time to order something from Starbucks. This is with you and the patient, okay? So one thing you want to make sure that you do before you go in there, look at the chart. If you don't have the chart, find out why the patient is there. If you have to, because it's a brand new patient and they tell you got to go do something with this patient, go in and talk to them. Hey, I understand you came into the hospital today. What's going on? Can you give me just a little bit of history of what's happening? I'm the respiratory therapist. Somebody told me you needed breathing treatment. So I need to know, what kind of medications do you use? And are they working? What is it that's going on at this particular point? So basically, you can ask to be involved without having to be asked to be involved. Tell them who you are. Tell them why you're there. Do what they need to be doing. Patient tells you, man, I have bed bugs at home and I think I brought them into the hospital. Don't go running out of the room screaming, oh my gosh, there's bed bugs. Ah! Okay. Something, though, you need to bring to somebody else's attention. Did you know this person's got a lot of bed bugs at home? They can scream in the courtyard or something like that. You cannot judge these folks. That is not your job, okay? Remember, your job is to take care of them and do the best that you can. So here's a few interviews, do's and don'ts. Everybody has to have do's and don'ts. You can sit or stand where the patient can see you. If you move anything, make sure you put it back. But don't stand at the door and yell at them. And don't stand at the foot of the bed playing with bed controls, okay? Be empathetic. You can also be compassionate, okay? If you move something again, put it back. Be sympathetic. No, I'm not going to sit there and cry over what you just told me. I'm so sorry. I didn't realize that, that's not what they need. They need someone who can say, let's go forward with this, okay? So the other thing, too, is don't put words in their mouth. Now, sometimes people will do this. When we used to have to do CPT, they would say, well, the patient didn't want it. Well, what do you mean the patient didn't want it? They've been taking it every other time. Oh, well, they just told me they didn't want it. Okay. And you go to see the patient. Hey, how are you doing? I'm fine. I understand that you didn't want your CPT. Well, I really did, but that therapist told me that, she was going to lunch and didn't have enough time to do it. So, we both agreed that I wasn't going to do it. Interesting. So how do we get people to talk to us? First of all, it's not a police interrogation. You're not there with, give me the facts, ma'am. Don't be rambling, okay? Talk to these patients at their level. This doesn't mean that you talk at baby talk or, anything else. Listen to them and it'll give you an idea what their educational background is. It'll give you an idea of what they're doing and what they can understand. And then talk with them using that information. All right? If this patient is not making much sense for some reason too, what you need to do is find somebody else who can also help you, okay? Because there's other people who can tell you a little bit more information in some cases. I love the do not impress them with medical terminology. If you want to see a patient lose everything, sit there and tell them, I understand you're here because you're having a major bronchial problem, that your airways have constricted, and as a result of that, there's a massive abundance of mucus in them, and this is preventing you from breathing effectively, and now you're becoming hypoxic and hypoxemia, building up CO2. Yeah, the patient's like, yeah, whatever. Okay. So, be careful. Talk to them so they understand you. All right. So, somebody common interview mistakes for the most part. Take a look at these, okay? Uh, these are things that we need to make sure that we either put on a card and take with us, and when we look down and see we're starting to make some of these mistakes, we need to start over. So we have a comprehensive health history. Your comprehensive health history is, who is this patient, okay? What do we know about them? Things that we're looking at is the day, the time, what is the age of this patient? Why are they here? What kind of background do they have? The box 2-1 has got a lot of this information. Take a look at it. When you do your case study, this is some of the information you're going to address in your case study. Okay. So some of the components, as you can see, chief complaint, what brought you here, what, why are you here, basically, is what we're looking for. It's always kind of interesting. You ask a patient, how did you get here? And they'll go, well, my son brought me. Oh, okay, well, I now have some information. Their son brought them. Maybe I should rephrase this question a little bit, okay? Past medical history, why do I care? Because that may be impacting what's going on at this particular point in time. Personal social history, smoking, things like drug use, all of that. It is really funny. Sometimes we listen to the case studies. People will go, yeah, Mr. Jones was smoking some marijuana, had some problems with it and everything. The doc came in and asked him if he used illicit drugs, and he said, no, I smoke cigarettes, but that's about the extent of it. So sometimes you'll find out a whole lot more information than other people will. And then you're going to do that physical exam that applies to us as respiratory therapists. However, you're also going to look at the physical exam from the physician to see what their take is. So we're going to take a look when we review the systems. We want to go the good things and the bad things. Pertinent negatives are things that you should have an answer to, but the answer is not what you're receiving. For example, if someone tells you have a really bad infection, this is the reason why I came in, and you're looking and their leg or arm is really swollen and red and warm when you touch it, and you ask them, are you having a fever? Oh, no, I'm fine. No fevers. Perhaps that's not quite true, okay? And then pertinent positives, well, yeah, maybe I am running a fever. When you're sitting here diaphoretic, you probably are, okay? And then, you can ask them about what's going on with them. What are their symptoms, as far as that goes. From their symptoms, you can also sometimes pick up the signs of what's happening. So there it is, chief complaint. Why are you here? If there's more than one symptom, list them out, okay? And most of this information is going to come from the patient, the significant other, another caregiver. Okay, as far as those go. These are just information that you need to be able to put things together. When you're looking at a symptom, remember, a symptom is not a sign. A symptom is basically, what does this patient think about what's going on? And some of them that come together, people have all these really cool things that they use. This is one that I got out of one of the books. It's basically old charts. And it's basically, onsets. When did it happen? Where is it? How long has it lasted? Is it painful? Does it ever stop? What makes it worse? Is it a radiating type pain? When does it happen again, and how severe is it? So we can look at these and make up our own mnemonics so that we can ask these patients a little bit more about what's going on, or their caregivers. So some of the common symptoms we see with patients who have cardiopulmonary disorders are cough and sputum and phlegm. Remember, sputum. Sputum comes through your mouth. Phlegm doesn't. Both of them originate in the lung. However, a phlegm sample is what you're suctioning out of these patients because it's not coming out of their mouth, okay? A sputum sample is what they're going to cough up and give to you. Just let go with it. Hemoptysis, are you coughing up blood? And how long have you been coughing up blood, and how much? Are you short of breath? Are they wheezing? What else is happening? Now, cough is one of the most common things we see in pulmonary patients. It's going to send them to the physician. There may not be some other things going on. I have this dry tickle in the back of my throat. It could be postnasal drip. It could be something else, but it doesn't necessarily mean there's something worse that's going on. Sometimes it's just, what are we going to do with this at this particular point? There is a common disease manifestation, though, that sends their patients to the MD. Make sure you look in your book, and then you can tell me exactly what it is. We want to know a little bit about dizziness. We want to know about swelling of the ankles, fever, chills, and night sweats. That has something to go with it that can make us really concerned, okay? We see long bone joint muscle pain. We see a lot of this with our patients who have COPD. They have a lot of pain as a result of their diseases, okay? Headaches, altered mental status, loss of appetite, nausea, vomiting. Remember when we talked about all the stuff in emergency care, we said everything causes nausea, vomiting right along there with that pulmonary edema, okay? And so there's different causes for bilateral edema, different causes for unilateral edema. Take a look at your book and see if you can find out what those are. We haven't talked about the Glasgow Coma Score, but it is something that we can use to assess mental status. We're going to talk quite a bit about that when we get into trauma, and especially head trauma. So sputum color is always something good to know. I would probably know just a little bit about it because it's always something good to know. Brown, dark, old blood, bright red, fresh blood. It could be from a tumor, it could be from TB. Normally clear, translucent is normal, copious means a lot. Green, now we're looking at stagnant sputum or gram negative. Remember Pseudomonas, oh my heavens, once you smell Pseudomonas, you don't forget it. Very foul smelling, it's like a sickly sweet smell. For the most part, mucoid, white and gray. There's your asthma. Pink and frothy or white and frothy is your pulmonary edema. Tenacious. Tenacious means it's going to stick together. It's hard to get out. And if your patient's really, really dry, it's going to be hard to get out. So how can you help this patient who's really, really dry? Something you talked about in second semester. Vicious is another one, nice and sticky, okay. Anything yellow or opaque means you have a infection of some sort. It's a presence of the white blood cells. Sometimes you'll see people coming in, they'll have yellow secretions, they go to green secretions, go back to yellow secretions, and there's part of your steps of that bacterial problem that they have. History of present illness, past history. Tell me a little bit about what's going on with you at this particular point. You really need to listen to these patients. There's some forms that you can follow that'll give you an idea of questions to ask and things to look for. And then a little bit more about your past history, because a lot of times what happened to your family or has happened to you earlier is now impacting what's going on. So your general survey when you're interviewing your patient, you got to look at them. I'm sorry, looking out the window is not acceptable. Determine level of consciousness. You want to look for any signs of distress. If they're leaning over and holding their side, that's not the time to go, can you sit up for me? You're talking to the floor. There may be something else happening. So, look at them, talk to them, listen to them, determine, are they really nervous? It's interesting to meet a patient who's like 42 years old and you're talking to them and you're going, are you nervous? You look like you are, playing with the bed sheet and everything. Man, I haven't been in a hospital since the day I was born. I don't know what's going on. You read all these horror stories about it. That tells me something that I can use when I'm helping this patient, okay? Look at the face for affect. Affect is what tells me how this person is going to interact with me. When we talked about patients in shock, remember their eyes were somewhat glazed over. They had this hardly any affect. They were just there. When you guys are not listening to what I say, you have no affect, okay? If I tell a really funny joke, which of course I don't have that many, and you laugh, you have a different affect. So we want to see how the patient interacts with us, okay? Then we always learn a little bit about body and breath odors. Do not mistaken DKA for alcohol intoxication. Patients have suffered from things like that. People go, oh, that guy in there is drunk. He's got that sweet, smelly stuff. I guess he's been drinking sangria. No, he's not. He's got a DKA. Look at him. Look at the lack of affect. Look at this ABG result, okay? Let's take a look at it. Pulmonary infections, you'll never forget those smells either. Then we want to know, can they move and how well do they move? This was interesting. We were doing stress test, and this gentleman was scheduled to do a treadmill. He had to walk on the treadmill. And we went down to get him. And as we're walking back to the department, he's stopping and holding on to the wall. And I went, do you have a problem with your walking? Yeah, I'm not very good at it. Well, how are you going to put somebody who can't walk on a treadmill? And so finally got him into the department, sat him down, and then we called the physician. And the physician came down, evaluated him, and we did something else. Vital signs. Okay, use the correct cuff size. A big cuff on a small person, you're going to have a very low blood pressure. A tight cuff on a big person, you're going to have a higher blood pressure, okay? Make sure this patient is sitting up, they're comfortable, their feet are flat on the floor. Do not let them lean forward. Do not let them cross their legs or their ankles, okay? And there you can see, centered over the brachial artery, secure it snugly, pump up to about 30 millimeters above suspected systolic pressure. Always was kind of cool when we were doing this and listening because sometimes you can hear it and you know where it stops, so you know how much higher to go up at that particular point. Keep that arm at about mid-chest level, okay, and relax it. What's interesting, we need to make sure we understand this. If the patient has their arm down, that blood pressure is going up. If they have their arm up, that blood pressure is going down, okay? So here's some average range for vital signs, and you can see with the newborn all the way up to the older adult. And in this case, this range went up to greater than 70. One of the things that we're going to talk about, especially with our people of age, is as they get older, their temperatures go down, all right? Why is that important? That's important because if this person is running an average temperature of 96 degrees, and we sit there and we take their temperature and we go, oh, your temperature's 99, you're not running a temperature because normal's 98. If theirs is 96, they're running a temperature, there's a 3-degree variance. So we need to keep that in mind, okay? Pulse rate, basically the same. Respirations, you notice they have 12 to 20. We actually have increased respiration somewhere between 16 to 25 breaths per minute. And the question comes up, well, why is that? It's a really good description in chapter 13, and basically it's this. as we age, remember when you're 25, your lungs have aged and you're becoming an old person. Your lungs get a little bit more saggy baggy at that particular point, and they lose some of that elasticity. The other thing that happens, though, is that parts of the lung get much stiffer, especially the cartilage and things like that. And so their tidal volumes have a tendency to decrease. If you remember, the formula for minute ventilation is tidal volume times respiratory rate. And we have a minute ventilation that's based, sometimes you can base it off what their ideal body weight is in kilos, but we'll say the minute ventilation is between 5 to 6 liters per minute. In order to keep that 5 to 6 liters per minute, they have to increase their respiratory rate because the tidal volume is going down. Okay, and so it could be, this person could be quite normal if their respiratory rate's 22 breaths per minute. They'll tell you, I feel fine, I don't know what the problem is, blah, 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 and they probably are right. You also know blood pressures. We're still sitting here trying to figure out what is a blood pressure, what's a good one. Next slide's going to show you some of the newer numbers that come into it. 120/80 is really at the top end of what's normal. Beyond that is where we start to see prehypertension. And once you hit 140/90 or something around that area, now you have hypertension. So this might be a little hard to see, but that's basically what that is. We want to do heart rate and rhythm. Remember, you can do the radial pulse. Normal is somewhere between 60 to 100. Anything greater than 100 is always tachycardia. Less than 60 is bradycardia. However, you need to remember there are people who live with low heart rates. Athletes, if you're out there running every day, 2 or 3 miles, climbing the mountains, bicycling, things like that, you're probably running a heart rate of about 48 or something like that. That is normal for them. And so at that particular point in time, don't be sitting there going, your heart rate's a little bit low, maybe we should give you some atropine. That's not going to help them, okay? It's going to make things worse. So just be aware of that. Is the rhythm regular? Are you sitting there and you count 1 and 2 and 3 and 4 and 5? Or is it one of these there's like a little one behind it. Oh, there's 3, 4, and 5 because they're together. So, is there a dysrhythmia going on at this particular point? Pulse pressure, I know you guys remember that, the difference between systolic, diastolic. Normal pulse pressure, somewhere around 35 to 40. Remember that you have pulsus paradoxus. When you are taking blood pressures, when you're feeling pulses, whatever, remember during systole, the pressure drops, and it normally drops about 5 millimeters of mercury. Anything greater than 10 drop is pulsus paradoxus, okay? So we want to be aware of that because that tells us there's a problem with this patient. Respiratory rate and rhythm. We just talked about why patients have higher respiratory rates. Take a look at how they're breathing. Are they just using their upper portion of their lungs? You can teach them how to breathe. Remember, you learned that in therapeutics. How are they sitting? Okay. One of the things we talk about when we talk about sometimes patients in the ICU, their knees are sitting on their chest underneath their chin, and they're going, the patient's not breathing well. And you're looking and they're going, I wonder if we sat them up, if that would help a little bit. Well, it could, but I'm not too sure. So then we go in and we take those knees and we put them back down on the bed and then sit them up. It's amazing. They breathe so much better. Are they using accessory muscles? Okay. And then, what is the rate at that particular point? When you're doing your respiratory rate, a lot of people tell you do 15 seconds multiplied by 4. You're really, really good. Sometimes, if you don't know this patient, do the respiratory rate for a whole minute. Temperature. As I said, with our people of age, it's much lower in some cases. You have your oral temperature. Excuse me. Sometimes it's very difficult to do that. We had a patient one time and we had to do something with him, and we said, we got to do your temperature. I don't know why we were doing an oral temperature. Put it in there. It's only going to take, a couple of seconds. And before it ever had a chance to read, he's like, oh, and we're like, no, 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 can you just not talk for a minute or two? Yeah, but, yeah, okay. So then we had to go get something else to be able to do it. Rectal is a little bit higher, axillary is lower. Tympanic is what we're doing a lot of that. We have some of those new thermometers that you don't even have to touch the person, that just scans them and reads it. Temperature is higher in the afternoon, lowest in the morning, okay? Simply because that's the way the body is. If you're a shift worker, guess what? Your temperature is higher in the afternoon, in the evening, lower in the afternoon when you get up. So this is somebody who's pretty normal at that particular point. And this just shows you how to go ahead and convert temperatures at this point. Remember Celsius and Fahrenheit. I like about this chart because you can see where they put their normal, then hypothermia, less than 95 degrees. Pyrexia means you have a fever. Hyperpyrexia means that you're febrile. Okay, a higher fever. Remember, febrile does mean fever. And there it is. How do you get your temperature? You balance it between heat and cold at this particular point. The hypothalamus, when we talk about cranial problems, if it's damaged, you've lost your heat and control. It's the major thing that helps control our heat and our coolness. Fever is, there it is, febrile, metabolic. The thing to remember this, if a patient is running a fever, they're producing more CO2 and using more oxygen. We sometimes forget that. We go in there, this guy's running 102 degree temperature, they're not on oxygen, and we're going, is there a reason why they're not on oxygen? Yeah, when we did the pulse ox, and you were going, let's take another look at that pulse ox, because they're using a lot of oxygen, producing a lot of CO2. And there it is for every 1 degree Celsius increased by 10% consumption and CO2 production. And people remember the first sign of hypoxemia forever and ever is tachycardia. You are correct. Hypothermia, below body temperature. We can see this with severe head injury and damage to the hypothalamus also. Exposure to cold temperatures. There you see your shivering and vasoconstriction. O2 consumption goes down, CO2 production also goes down. And we see a slower respiratory rate. We also see a slower heart rate. So one of the things that we get used to doing, and we do this also in the intensive care unit, we do a lot of trending of vital signs. This is a really cool thing because now you have a previous history, all right? So you always want to think about that. What was it yesterday? What was it 2 hours ago? What's going on here with this patient? We want to take a look at it. Differential diagnosis is really, really cool. There's some really good differential diagnosis articles. Most of them come from StatPub, which is part of the NIH or something like that. And they'll tell you all about a disease, and then it'll come down and tell you at the bottom differential diagnosis to tell you what other things it could be. Now, the question is why is that important? And I'm going to tell you, too, if you get a chance to talk to some of the ED nurses, those guys are really, really good at this. Patient comes in, everybody goes, oh, I think he has pneumonia. So we go ahead and we have in our head, what should I see with pneumonia? Increased temperature, bronchial breath sounds in the periphery, coughing up maybe some green and yellow stuff, blah, 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 whatever else goes with it. Well, we do everything we need to assess him, and it doesn't fit, okay? So now we have to go back to the beginning. What else could this be? If we thought about what else it could be in addition to pneumonia, we don't have to go back to the beginning because we have this other one that's sitting there, and now we can see, does this fit better, okay? So it's really important to start thinking about what diseases mimic each other. Bedside assessment, remember IPPA. IPPA. Inspection, palpation, percussion, auscultation. Big four. You got to know how to do those. And for patients who can't really tell you a little bit about their pain scale, we have this. This works out really good. A lot of folks go, how bad is this pain? Someone goes, it's a dead, it's a dead, it's a broken fingernail. Okay, you said it's 10, we'll take it at 10. Well, that's interesting. Height and weight, I's and O's. You guys know what goes in should come out. If you have a person that you've given 2,000 mLs of fluid to and you got 750 back, where's the other 1,250? And is it going to affect their breathing? Other things, cardiopulmonary distress again, anxiety, pain. How many of you guys have been in pain, dropped a brick on your foot, or smashed your finger when you were trying to hammer something? Most of the time you didn't sit there and go, I think I broke my foot, or, I hammered my finger. We're normally sitting there going, ah! It affects us. It affects our cardiopulmonary status and also how we breathe, okay? So we need to be aware of that. There's your level of consciousness or sensorium. You have to have good cerebral oxygen to be able to have a good sensorium. And you need to know who you are, where you are, why you're there, and what time it is. It's always interesting talking to patients, and you can ask them, hi, Mrs. Jones, how are you? Oh, honey, I am so good. Okay, well, do you know what today is? Not really. They didn't change the calendar. Okay, that's kind of cheating, but that's all right. Do you know where you are? I think I'm in the church basement. Okay, well, that sounds cool. What are you doing down here in the church basement? That's why I came looking for you. And then this conversation goes on. Would you say she has a good sensorium? Maybe a little iffy. Okay. People who are hypoxic are restless. And we need to know that when we start to see them. They also get very confused and disoriented. They also can be comatose at this particular point. And this is where the Glasgow Coma Score comes in. One thing you must remember about the Glasgow Coma Score, it tells me here and now. It does not tell me 2 hours from now. It does not tell me a day from now. It does not tell me a week from now. The Glasgow Coma Score only tells me what's going on here and now at this particular point in time. So again, for part of your exam, facial expression, how are they breathing? Look at the eyes. A lot of times we ignore those eyes, but we really need to take a look at them. You can see the cranial nerves 2 and 3 have to be intact in order for these eyes to work. Well, why do we worry about that? One of the things you need to know is if somebody came in with a stroke and they look like they were doing really, really good, and then all of a sudden they're not doing quite as well, and you look at their eyes and one eye pupil is blown, you got a problem with one of the cranial nerves too, okay? Perla, pupils equal reactive, responsive to light and accommodation. When you shine a light in their eyes, it should constrict. When you take it away, it should dilate. How do you think the police know somebody's using narcotics? So abnormal findings, it could be head trauma, certain medications. Brain death is one. The catecholamines and atropine, dilated and fixed. Okay, we know that that's what's going to happen. If you look at this picture of this young lady, her pupil is dilated and fixed. Pure sympathetic stimulants, pinpoint pupils, okay? And then a problem with the cranial nerve 3, we see ptosis or drooping eyelids. I'm going to show you a picture of those on the next one. So these are constricted, the one behind it. This is a constricted pupil, tells you some of the drugs that can cause this. Red eyes, something like marijuana, benzodiazepines will do this too. Dilated pupil, there's your amphetamines, crack cocaine, opiates on occasions, heroin, marijuana. All those good things will do that for you. And this was kind of a cool one. This one came from Very Well. As you can see, the normal sized pupils, people with aneurysms, cluster headaches, all the way up to syphilis. Here's your ptosis, as you can see. What's interesting about ptosis, and it's something we really don't think about, there's also something else. One of the questions I would ask on occasions, just as when you're having in-services or something like that, is they'll ask you, what color is your significant other one's eyes? And it's amazing. People sit there and go, blue, perhaps? Interesting, because we don't really make note of it. And the same thing can happen with our patients. But some of the things with ptosis, if you notice, when you look in someone's eyes, there's that little light. And we know that they're with us when that light is there. If you're looking at this picture, take a look. You can only see a tiny little bit of the light in one eye and not in the other. And the reason for that is those drooping eyelids. Okay? Why are we concerned? Look at number 3 over here. Respiratory failure, myasthenia gravis. Okay? Need to be aware of that. There are reasons why this happens. And JVD, want to take a look at those. That's going to tell us a little bit about what's going on with this patient. The other thing we want when we inspect the neck is the tracheal position. Very easy to do, okay? You don't have to choke the patient. And if it's moved, have we had a collapse of the upper lobe? Do they have a pneumothorax? Pneumothoraxes move everything away. Atelectasis pulls it towards it. Pleural effusion, depending on how big it is, can either push it away or pull it towards it. Lung tumors can do the same thing. If you notice, the patient is at a 45-degree angle when you do this. So the JVD reflects the volume of pressure on the right side of the heart. The major reason for this is right-sided heart failure. Secondary cause is finally left-sided heart failure. And the last one is hypervolemia. There's too much fluid at this particular point, but this will tell you about what it is. Remember that 45 degrees and anything greater than 3 to 4 centimeters is a problem. This just shows you how to do it. Carotid pulses are always kind of cool. Gives us information about the cardiac function. It can talk about stenosis or aortic valve insufficiency. So remember, stenosis is the hardening of the area. Insufficiency means the valve is not closing as much as it needs to. Head of the bed, about 30 degrees. When you're doing anything with a carotid pulse, do one side, not both. Sometimes when a person is in a flood or a fib, something like that, you can do a carotid massage, but you only side one side. If you do two, you won't have to worry about the patient anymore, but that's not really what you want to do, okay? If you have decreased blood flow, you can have syncope. Remember, syncope is fainting, okay? And you can figure out what's going on. How do you palpate the carotid artery? Place your fingers near the upper neck between the sternomastoid and trachea, roughly at the level of the cricoid cartilage, and that's where you'll find it. Cardiogenic shock, small, thready, weak pulses. If it's aortic insufficiency, bounding, stenosis, it's a delayed cardiac upstrike, okay? Now, one thing I want to mention, I'm going to mention it, and I forgot to, before you touch these patients, you need to tell them you're going to touch them. If they're awake and alert, if they're not, and you have to do something, you have to do it. But if these patients, even if they don't look like they're all that there, still tell them what you're doing, okay? Thrills and bruits. Thrills and bruits are kind of interesting. Thrills are like a humming vibration. It's indicative of a murmur. Bruits are murmur-like vascular sounds, but they're not of cardiac origin, okay? Let's see here. With a bruit for the most part too, it results from blood flowing through a narrow or partially occluded artery, okay? The specific character of your bruit, its location, the time of its occurrence, all help with the diagnosis of what's going on with this patient, okay? They're very low frequency. and they're best heard with the bell of your stethoscope. Isn't that a pretty kitty? So how do you listen to cardiac buoys? Basically, for the most part, because you're looking for cardiovascular disease, have them hold their breath, and you should hear that whooshing sound. And that will tell you a little bit about what's going on. And you can see a cardiac buoy with or without the thrill suggest arterial narrowing. So that just tells you a little bit how to do it.